Hello, everyone. Welcome to our program today from ecancer. My name is Neal Shore. I'm the Medical Director of Carolina Urologic Research Center. We're here live today in Chicago at ASCO 2017. Today is June 5th. I'm truly honored to have the opportunity to talk with my friends and my colleagues about some of the highlights that occurred this weekend at ASCO, some of the challenges that we still face in the diagnosis and management of prostate cancer, and what is the future? What will it look like? What are some additional learnings that we want to attain? What's some of the newer trials that pique our interest? Most importantly today is that this is an interactive program. So you have the ability to write down and email in your questions. We want to have a very interactive discussion as well as a presentation of some really profound data which potentially should be very practice-changing. So I'm truly honored, and it's a great pleasure to introduce to you to my immediate right, Karim Fizazi, Professor of Medical Oncology at the Institut of Gustave Roussey in France. And next to Karim, my very good friend Nick James, who's a Professor of Medical Oncology at University of Birmingham in the UK. And also my great friend Kurt Miller, Professor of Urology, who's now at Charité Berlin in Germany. So it's really going to be a fun program. I really would hope that throughout the program, questions that come up to any one of the individual panel members or to the entire panel, please send those in. We'll try to address as many questions as possible. So here are some of our disclosures. As you can see, a lot of involvement for all of us with many different industry and without government sources as well. So here are our objectives today. We want to discuss the current challenges that face you, whether you're a medical oncologist, a urologist, a radiation oncologist. If you're devoted to taking care of patients with prostate cancer, what are the issues around diagnosis and management? And what's particularly exciting today is we're going to review two groundbreaking phase 3 trials. I'm so happy that the global PIs for both trials, Karim and Nick, are here to discuss them. And will this research, will it change your practice management? And that's ultimately so important to why we do these trials. And what does the future hold regarding ongoing and proposed trials? And how will the learnings and the evidence that we have at ASCO in 2017, how will that shape our decision making? So our first question for the audience is, and we welcome the European Asian audience today, and of note, on ecancer.org, you'll be able to, after 24 hours, get access to this live program that you're seeing today. But what are the greatest challenges today for prostate cancer management? Is it treatment of patients with high-risk prostate cancer? Is it the management of castration-resistant prostate cancer? Is it understanding the clinical utility of genomic assays, urine, serum, tissue biomarkers? Or is it the interpretation and utilization of diagnostic imaging? Now, of course, all of these are important, but we'd like you to just pick the one that's most germane and interesting and challenging to you as an audience member. But let me first start with you, Karim, and maybe you can, opine a little bit. And they're big topics. If you could take from the bottom the issues regarding utilization of markers, whether they be genomic assays, protein, and urine, serum, tissue, and diagnostic imaging. Big ask of you, but what are the things that just come, front of mind for you?
Sure. So regarding the last question about imaging, we've been living in advanced disease or even in localized disease, mainly with bone scan because metastatic prostate cancer is a bone disease mostly, and with CT scan because you might see some visceral metastasis or lymph node metastasis, and we've done that for years and years. In the last, I think, decade, let's say, this has probably evolved a bit with the use of whole-body MRI and PET choline, but there was still some debate. I think the next big question for the coming 1 or 2 years will be whether PSMA PET will totally change the field. And it really seems that PSMA PET is really able to identify tiny metastases that the other imaging are not able to do. And if so, then really we might totally change the way we will treat these patients, not only locally, but also systematically. Now, regarding the biomarker question, when you think about it, among the 4 big cancers, at least in the Western world, breast cancer, lung cancer, colorectal, and prostate cancer is the only cancer where we're not using really precision medicine. So we're not making all a decision based on a given biomarker. And again, I think this is just about to change. We thought probably 2 years ago, 3 years ago, that perhaps the AR-V7 variants would be the first biomarker to come to help us for decision making. I'm not totally sure about that, to be honest, and the biology of the AR is probably much more complex, so there's still much more work to do there. Actually, the first biomarker that may come out very soon is about DNA repair. And this is because we now know that much more patients than we originally thought have DNA repair abnormalities, either germline or somatic, and also that we can target that. So I think this will really change quite soon.
Well, you're hitting incredibly important points. Thank you. We'll get back to that later on when we have some really interesting abstracts which are going to speak to exactly what you're describing. Nick, you've been, championing the STAMPEDE multi-stage, multi-arm. It's exceptional, and once again, you've brought some phenomenal information to us. It's almost a semi-annual event, thanks to you and your colleagues. But let me ask you about the management of castration-resistant prostate cancer. Just the blue sky look. What are some of the things that you think about for a short answer?
So I think the thing that is emerging in our practice, and it is being driven by PET imaging, just as Karim said. So we're currently using choline PET. We're in the process of switching to PSMA. So one of the things that that we've seen, which has been actually dovetailing in with the presentations that Karim and I have done over the last 2 days, is we've seen spectacular responses to upfront abiraterone. And then when these patients become castrate refractory, the question arises, is the disease different to the disease we saw before? And I think the answer to that is yes. And one of the things we've seen, which we've been very intrigued by, is we've seen patients starting with very extensively hot bone scans, getting PSA responses to undetectable levels, then relapsing with just 1 or 2 sites of disease, which we're mostly imaging on PET, because what we find is that some lesions are hot and some of the previous lesions are cold. So we've been moving towards giving radical radiotherapy to oligometastatic recurrences in previously, if you like, polymetastatic disease. And talking to my colleagues, particularly at the Royal Marsden, where they've got very good access to PET as well, this seems to be a theme that they've seen as well. So I think there's going to be a whole new chapter in, if you like, the post-abiraterone CRPC space, where they've had abiraterone up front, where the treatment paradigm may actually turn out to be different to the CRPC pattern we have at the moment. And I think unraveling that is going to be really very interesting.
So yeah, you've touched on great future learnings, controversies, oligometastatic disease, and we'll get into the STAMPEDE and abiraterone data as well as LATITUDE. Yeah. Kurt, finally, in treating patients with newly diagnosed high-risk prostate cancer, what are your thoughts?
Well, yeah, it depends on really if we are on the metastatic side or on the non-metastatic side, and somewhere in between is what just has been discussed, is oligometastatic disease, and there's a discussion on should we treat the primary and oligometastatic disease. And I mean, interestingly, you give 1 more metastasis and then it's 4, and all of a sudden you're in high volume metastatic disease, and discuss chemohormone therapy or other combinations, which we will discuss probably in a couple of minutes. So there is still it's a pretty crude classification, and we would need more differentiation here, as Karim has pointed out.
Gentlemen, thank you. A lot more discussion in front of us. Let's get right to some of the really big highlights of ASCO. Again, awesome to have both Karim and Nick here to describe their presentations, which were just jam-packed. But anyway, thank you for Karim to present the LATITUDE data.
Thank you, Neal. So this is the LATITUDE phase 3 trial, which was testing abiraterone and prednisone in patients with de novo metastatic prostate cancer. So the data were presented yesterday at this ASCO meeting. And again, this is really focusing on patients with de novo metastatic disease. The incidence varies a lot across countries. For example, here in the US, it is thought to be around 3%, but it's rising. probably around 6% in Europe, Latin America. But if you go to large countries from Asia, such as China or India, it can raise to up to 60% of men who are diagnosed with prostate cancer. So it's a big thing. Of course, as we all know, historically, we've been using androgen deprivation therapy for these men, and this is because it works, at least at the beginning, in almost 100% of them. Having said that, by a year, these men have developed resistance to castration, at least for half of them. And this is largely driven by reactivation of the AR signaling. So as we probably also all know, the field has changed 2 years ago, and the standard of care has changed thanks to 3 randomized trials, Docetaxel, Charted, and STAMPEDE, that could establish a role for Docetaxel in terms of not only progression-free survival, but also overall survival, with hazard ratio ranging from 0.73 to 0.88 in overall survival. So ALTITUDE was about abiraterone. Abiraterone is a CYP17 inhibitor, so it's preventing strongly the making of the androgens. Not only, of course, from the testes, but also the adrenal sources and prostate cancer sources as well. So it was a quite straightforward randomization, and we selected patients with de novo metastatic disease who were really at high risk of dying from their disease. High risk was defined as men with at least 2 of the 3 high-risk criteria, a high Gleason score, more than 3 bony lesions, and visceral metastasis. So it was a classical phase 3 trials where men were randomized in a 1-to-1 fashion to get castration plus or minus abiraterone and prednisone given at 5 milligrams daily, or of course placebos for abiraterone and prednisone. 2 co-primary endpoints, overall survival and rPFS. Big, large global trial, and Docetaxel was not used as a standard of care just because the trial was designed and completed its SAC role before the trials establishing the role of Docetaxel had read out. So classical population of patients with metastatic high-risk disease. I won't detail that too much. Many of them obviously had bony disease. Most of them had a high Gleason score, and actually most of them had many bone metastases. So nasty cancers, obviously. So this is the main and most important results about overall survival, one of the key co-primary endpoints. And what we saw was a 38% reduction in the risk of death. The median in the control arm was what we were expecting, so 34.7 months, and it was not even reached in the abiraterone arm with a 30-month median follow-up. So at 3 years, 66% versus 49% overall survival rates. So across subgroups, we saw a really benefit in terms of overall survival. This was true, for example, for patients in good and poor performance status, and also, and this is also very important, those with and without visceral metastasis. The second co-primary endpoint was the geographic progression-free survival, and here again, obviously, abiraterone wins. This was a 53% risk reduction in radiographic progression or death, medians less than 15 months in the control arm versus 33 months in the abiraterone arm, so this was more than twice improved. So this good data, I guess, came together with many other good findings in terms of time to PSA progression, time to pain progression, which is obviously very meaningful, time to symptomatic skeletal events, again, very meaningful, and time to chemotherapy, time to subsequent prostate cancer therapy, which are meaningful not only to patients, but also to society in terms of use of resources and cost. Generally speaking, the benefit that we saw was truly related to abiraterone use up front, and I'm saying that because most patients in the control arm received life-prolonging therapy such as Docetaxel, enzalutamide, abiraterone, cabazitaxel, radium-223. Actually, twice more patients received these drugs in the control arm. So this is really telling us that the benefit we see in overall survival is clearly linked to upfront abiraterone. In terms of safety, we basically saw what we already knew from the abiraterone experience, which is an excess in hypertension and hypokalemia, slight excess in transaminase increase, which is usually not an issue, and also slight excess in cardiac disorders. So in conclusion, LATITUDE clearly established that for these men with metastatic high-risk prostate cancer, using abiraterone and prednisone upfront significantly improves overall survival with a 38% reduction in risk of death, which is obviously just great, and also a significantly improvement in radiographic progression-free survival. Safety profile was not really an issue. It was really what we were expecting. And based on that, I really believe that we now have a new standard of care for these men, with abiraterone prednisone being added on top of castration. So the data were published yesterday in the New England Journal of Medicine, which is just great.
Well, that's fantastic, Karim. Congratulations to you, your co-investigators. And what a great opportunity for our audience and for everybody at ASCO to have your phase 3 trial and now Nick's very similar, some differences, we'll discuss them, looking at very similar populations, some nuanced differences, but really looking at that combination of abiraterone acetate with prednisolone and ADT. So thank you, Nick.
Okay, so obviously great to be presenting these things back to back, and the results are strikingly similar, and as you said, they've got some interesting differences as well. So these are the survival results from the abiraterone randomization in STAMPEDE, and so STAMPEDE has a number of different randomizations within it, so highlighted in yellow here are the patients we're looking at today. So I won't go over the rationale because Karim has just done it. So STAMPEDE includes a broader range, so newly diagnosed patients were 95% of the total going into the trial, and they had to be either metastatic, pelvic node positive, or high risk locally advanced. Now, all of those patients, the last one, the T34s, got radical radiotherapy as well, and about 60% of the node positive ones got radical radiotherapy as part of their base care. We did permit relapsing patients who'd had prior surgery or radiotherapy, but without significant amounts of hormone therapy, but actually they only made up 5% of the total, and pretty standard inclusion criteria in terms of performance status, consent, and so on. And stampedetrial.org is this trial website, all the protocols and everything on there if people want to look them up. We had a single primary outcome measure, of overall survival, and we also showed data on 3 of our secondary outcomes: failure-free survival, toxicity, and skeletal-related events. Simple one-to-one randomization, as with LATITUDE. Our target was a 25% survival improvement, and we had 3 interim analyses which we haven't published but which met their preset criteria. So we had 90% power and 0.025 one-sided alpha to do this analysis. So we recruited just under 2,000 men extremely quickly. The STAMPEDE design is very efficient at harvesting patients, if you like, into trials, and randomized as indicated equally. Patient characteristics obviously differ from LATITUDE. So PS2s were permitted, but only 1% of the total, 21% performance status 1, so just under 80% were PS0. Median age in the late 60s with a very big range, 39 up to 85. Just over half were metastatic, and just under 90% of those had bony metastases, so slightly lower bony metastasis proportion than LATITUDE. But then we have the other 2 populations, the node positive 20% and the node negative locally advanced 28%, which obviously aren't in LATITUDE at all. So there's some differences here. And as I already mentioned, the ones to whom you could give radical radiotherapy in the main did have radical radiotherapy. Our primary outcome was overall survival, and we had 262 control arm deaths at the point of the data freeze versus 184 on abiraterone. That gives you a hazard ratio of 0.63, which is astonishingly similar to the LATITUDE one at 0.62. I mean, it means the data are really very convincing. And that's a 37% improvement in survival. The curves you're seeing here are overall survival for the entire population, and then M0 and M1. For the M1 patients, I didn't show the curves, but the median survival is about 40 months, so a little bit longer than Latitude, reflecting the fact that we've got all of the metastatic patients in the M1s, not just the high volume ones, and so there are some differences in the metastatic patients. We're projecting, the dotted lines you can see on here are the mathematical best fit curves, so we can project those forwards. We're thinking the median survival of the metastatic patients is going to come out somewhere in the region of 6.5 to 7 years. And I was, given the hazard ratio is the same for Latitude, I would imagine that will be similar, slightly shorter, reflecting the worst prognosis. When we set STAMPEDE up, we were anticipating the median survival of these patients was 2 to 3 years. So that's a staggering improvement in a decade and a bit, driven by obviously all the new agents we have, but in particular shifting them upstream. So the forest plot, everything lines up as with Latitude over the point estimate for the trial. There's no convincing evidence of heterogeneity by the various stratification factors we looked at. We did look at metastatic status in more detail, and I'm sure this is going to generate a lot of discussion and controversy as to whether this is a dichotomous population and the two groups behave differently. There's not very many deaths here, which is obviously great news, but it means we can't fully power that sub-analysis. But if you look at the way that the confidence intervals and the point estimates line up, they overlie each other. There are more deaths in the M0 patients from non-prostate cancer causes, which obviously dilutes your benefit because they're not impacted by abiraterone. But the test for interaction by metastatic status is convincingly negative. It's not borderline negative. So our conclusion, as already stated, was there was no evidence of heterogeneity. So we feel these data apply to the M0s as much as the M1s. It was tested in the whole population. The whole population is positive, and the test for heterogeneity suggests the effect is uniform. And further evidence for the effect being uniform comes from the failure-free survival data. So we've got a lot more failure-free events. Huge difference as seen in Latitude with a hazard ratio of 0.29. We have slightly different criteria. 61 leading zeros in the p-value, a 71% improvement. Now the forest plot here, again, everything lines up over the point estimate, no good evidence of heterogeneity. And in this case, if anything, the hazard ratio is more favorable for the M0s, although we think there is no heterogeneity. So just skipping on to the skeletal-related events, as with Latitude, these are obviously extremely important. And what we saw, this is focusing on the metastatic ones on this curve, is a 0.45 hazard ratio, a 55% reduction in skeletal-related events, again mirroring Latitude. So the two trials are very consistent in their impact across all these key outcomes. We also looked at new treatments, and we looked at it in a slightly different way in terms of how we presented it. So from relapse, time to life-prolonging treatment is very similar, but the pattern of treatment is different. And actually, this is a point of difference between the trials. Because we are open label, clinicians knew if their patient had abiraterone or not, so we see far more use of AR targeting therapies in the control arm than we do in the abiraterone arm, which is a point of difference between the trials driven by the different design. Safety outcomes, I won't spend too much time on these. We saw almost exactly the same, increased cardiovascular hypertension, cardiac arrhythmias, and ALTs. In principle, these are grade 3 to 5 toxicities. In practice, they're not very hard to manage. Compliance, again, is a slight difference. We saw 21% stopping, apparently for excessive toxicity. We haven't yet matched that to the reported toxicity in those patients. For the patients stopping at 2 years, 70% just about got to completion of treatment. So our conclusions, very, very similar to Latitude. Abiraterone, acetate, and prednisolone improved survival by 37% across the population. Failure-free survival on a slightly different definition by 71%. SREs, or symptomatic skeletal events, what we collected, go down by 55%, which we think is clinically, and actually from the economic point of view, extremely important. Treatment was well tolerated, and the toxicity mirrors the CRPC setting. So as with Latitude, we think this should be part of the standard of care for men starting long-term androgen deprivation therapy, including the M0s. Now, I appreciate that might be controversial, but that was our conclusion.
So all I can say to that, go ahead.
Yeah, sorry, that's just the same slide. So, and again, in the New England.
Well, congratulations, Nick, to you as well. Phenomenal work. I guess my response would be wow to both, but I want to, Kurt, you've been involved in so many trials and you've seen so many things during your career and still actively doing so many great research projects and seeing patients. So what do you think of this data?
Yeah, it's still, as you say, at a considerable wow factor. It's in the uppermost percentile because that is really, in terms of consistency and in terms of the data set, it's really unique, I would say. And it is, I think for me, it's no question that it will be practice changing. And, Nick just opened Pandora's box in a way where I would say, well, where is the limit exactly? I mean, we will not discuss de novo metastatic disease. That's pretty clear. But then again, STAMPEDE has also M0 patients with lymph node metastasis. So where exactly do we stop with that? And that will be the questions of the future, I would think. For me, in metastatic disease, I think that's going to be the future standard.
So let me get back to you again, Kurt, on this. So how will this change your practice tomorrow when you get back from Chicago and you see patients? You've been a believer and an adapter to the chemohormonal approach.
Right.
What are you going to do now?
We're going to set up a letter because it's not approved yet. We're going to set up a letter for the insurance companies and to try to get this financed, because it will take like about 6 months until approval is through the process. And until that time, most probably patients will ask for it. News is around very, very quickly. And so I think that's the first practical step. We discussed this yesterday among German urologists. And to get the patient to this treatment, we would need to convince the insurance companies. There is some financial toxicity in comparison with chemohormone therapy. So that's the only hurdle, I would think.
Well, we are going to have a polling question, and we'll take the financial toxicity off the plate. I think it's really important that the audience heard the data, the safety, the tolerability. When abiraterone acetate was first approved, as well as the androgen receptor signaling inhibitors, enzalutamide, and the newer ones that are out there, it was in this advanced CRPC setting, post-chemo, then pre-chemo. And I think many people thought at the time, we can't give these in the androgen-sensitive state. There will be too much long-term toxicity. I'll start with you, Karim, and Nick, I would like you to weigh in too. Were either of you surprised with the incredible stability or in the safety adverse event profile? I mean, it's quite amazing for the duration of patients being on drug for so long.
Right. I guess you're very right. Actually, I had the same fear some years ago when we moved from CUFIO-1 to CUFIO-2, which was basically the pivotal post-Docetaxel phase 3 trial, when we know we were not using abiraterone for a long time, to the pre-Docetaxel setting, where some patients would receive abiraterone for years and years. And actually, I was quite reassured when I saw that even with long exposure to abiraterone prednisone, there was no real increase in the toxicity burden. So, and actually, it's pretty much the same thing here in order to trials in castration-sensitive disease. Having said that, we need still to be cautious. These patients need to be monitored very closely in terms of hypertension and kalemia, and also their liver test needs to be monitored. And for specific patients who are at risk for cardiovascular issues, we need also probably to take our time, refer the patients to the cardiologist, make sure we can really handle the cardiac problems as best as we can before considering the drug. But generally speaking, this drug is quite well tolerated.
Yeah, so great comment regarding our patients who start off with ADT and or now abiraterone. Those who have baseline cardiovascular morbidities, we have to be more careful with them, and they're so long.
I think so. And actually we have little time, because in the trials, the patients had the possibility to start with castration alone and then be randomized after a month or two. So this really gives you a nice opportunity to discuss with the cardiologist in these specific cases.
So Nick, similar question to you regarding the AE safety profile, and then a little addition to it. You used prednisolone 5 milligrams daily.
Yes.
Karim in Latitude, you used the same. So is that now your recommendation in the CRPC population too? What are our learnings from that?
To be honest, I don't know. The toxicity and safety profile is fine with 5 milligrams. There is some concern because of the half-life of prednisolone that you're only suppressing the ACTH feedback loop half of the time. That didn't seem to matter very much, and I think the differences are subtle, to be honest. I think overall the toxicity, I entirely agree with Karim, was very manageable. We were concerned about long-term dosing, so in the M0 patients we had capped the treatments at 2 years and actually capped the ADT at 2 years as well. So that, because we didn't want to keep on dosing people, a lot of whom that do extremely well, just to come back to Kurt's point of how far to the left down the spectrum do you go. But basically it's a very well-tolerated treatment.
Kurt, what do you think about that for urologists? Medical oncologists are extremely comfortable with, steroid variation of preparation and medications. I think maybe urologists in the beginning when abiraterone acetate first came out, the notion of giving even low-dose prednisone was a little bit of a new learning period. There was some concern and worry. And this data resonate for you as well?
Well, as Nick said, I'm not sure if it really makes a difference in terms of 5 or 10 milligram, because with the 10 milligram, you didn't see much toxicity from the prednisone either. But in terms of urologists, I would say, I think after a couple of years getting used to prescribing prednisone, in the meantime, this is not an issue anymore. It will not be a hurdle for this type of therapy.
All right, so we're getting questions from the audience. Here's one for you, gentlemen. Will this data impact patients who have just begun taking docetaxel as upfront therapy based upon charted and STAMPEDE, chemohormonal, presuming on appropriate inclusion criteria? Should they cross over from ADT and docetaxel to ADT and abiraterone acetate? Similar would be, should they add abiraterone acetate? So two highly charged questions within that.
Should I take that one?
Please.
Okay. So, I don't think a patient who has started already Docetaxel and who's tolerated that well should discontinue. I mean, the benefit of Docetaxel on overall survival and PFS is quite well established. So if the patient is doing okay in terms of safety, I would probably recommend him to just continue and complete the 6 cycles. Now, whether abiraterone should be added on top of that, we just don't know at the moment. We are actually randomizing the questions right now in Europe in the PEACE-1 phase 3 trials, where patients are actually receiving ADT and Docetaxel as the standard of care, and we're randomizing the role of abiraterone and also that of local treatment with radiation therapy. So hopefully we will be able to complete the accrual in a year from now, or even perhaps less than that. But for now, I think we really don't have the answer. And when we asked the question yesterday at ASCO to the attendees, it was quite split in the audience as to whether people will be keen to combine already right now or wait for the data to mature and see whether we should do it or not.
So, Nick, what do you think about Karim's comments, but then also a nuance to that question? There's combining, but then what do you do if you've just completed your 6 cycles of docetaxel to the androgen-sensitive metastatic patient? Do you then, at some point, add abiraterone?
Well, I'd have to agree with Karim. I think it's tempting to infer that you might get the dual benefit, and we know that you can give docetaxel and abiraterone is active post-docetaxel because we've got very solid CRPC experience with that. I think I would have to say you really need trial data because it will be a financial cost, as Kurt has pointed out. I think the other thing I would re-echo is within STAMPEDE, the docetaxel and the abiraterone arms were recruiting it for an overlapping period of time. So we have about 600 men who, if you like, are randomized between docetaxel or abiraterone. So we're going to run that comparison formally and present that subject to it being accepted at ESMO in the autumn. We've submitted a late-breaking abstract place marker. But our take is that it looks, as Eric Small pointed this out in the discussion yesterday, that the charted survival advantage and the and the latitude survival advantage in the same population look to be very similar. So I don't think patients are missing out on survival gain by not having had abiraterone, given that they can have a docetaxel. And I think that is part of the answer as to what we'll be saying in clinic this week when we go back, is that actually you can have a treatment which will give you just as much benefit, but with different toxicity, obviously.
Great. Kurt, so here's a question that's saying, okay, I've in the future, it's sort of going forward, I've been on abiraterone, acetate, and prednisone and ADT for my androgen-sensitive metastatic disease, and now the patient's converted to CRPC. No new bone lesions, but multiple bone lesions. What would be what is your recommendation?
Yeah, obviously, this does not only change the way we treat hormone-sensitive disease, it will also change the way we treat castration-resistant disease. Because so far, I would say 80 to 90% of patients, at least in my country, have gotten either abiraterone or enzalutamide as first-line therapy in CRPC. And now, it obviously doesn't make sense to give them abiraterone, which they already have. And it probably doesn't make sense to give them enzalutamide with a potential 25% response rate for like 5 months at best. So yes, it will change the way we treat CRPC, and probably docetaxel will now again move to first-line CRPC treatment in these patients, because that's probably the most or the best next step once you are under progression getting ABI and ADT.
So another question, both the LATITUDE and the STAMPEDE demonstrated highly statistically significant delays in SRE. By the way, both of your data sets had lots of zeros in those p-values. It was pretty darn impressive. Can you tell us about the use of anti-resorptives in the trial? Do you have that information? Zoledronic acid, denosumab?
So in the upfront therapy, previously in STAMPEDE, we had shown pretty conclusively that upfront zoledronic acid added no benefit at all. It gave patients ONJ, didn't have an impact on bony outcomes or survival. So we don't think we have any anti-resorptive therapy prior to relapse. There may be some post-relapse. It's hard for us to capture that data. Okay. But certainly pre-relapse, there will have been no use, I don't think, in the STAMPEDE population.
LATITUDE?
Yeah, pretty much the same. I mean, the role of denosumab and zoledronic acid is really established in castration-resistant disease. So some patients received it in LATITUDE for castration-sensitive disease with basically no data, but it's really a minority.
So earlier, here's a question about the cost of therapy. And Nick, you mentioned the economic utility. I'm sure you must have both of in your data sets more health-related quality of life outcome data to talk about. So as we move to this throughout the world of value-based care,
sure.
Can you comment on this issue of cost versus quality of life, toxicity, in making a decision between taxane-based therapy and an oral androgen biosynthesis inhibitor?
Yeah, so we've just analysed our quality of life data from the docetaxel thing. We haven't published it yet, it's the papers in preparation. But the striking thing about that is that quality of life goes up if you have docetaxel, not down overall. You obviously have a dip while you're having it, but once you've had it, there is a quality-adjusted life year gain in the docetaxel arms, M0 and M1, compared to the control arms in our earlier data. And when we looked at the health economics of that, it turned out that upfront docetaxel was cost-effective. In fact, it was cost-saving in the M0 setting and very low cost in the metastatic setting. And the thing that drove that was the reduction in SREs, because SREs are expensive and really hit your quality of life. So preventing a lot of SREs is very cost-effective. So I think although there is a cost to abiraterone, we've seen bigger effects on time to relapse and SREs than we saw with docetaxel, although it factors down to the same survival effect probably. So I think it probably will turn out to be cost effective. I mean, crudely, you have 18 months of docetaxel, of abiraterone in the castrate refractory setting to give you maybe 6 months extra survival, and that was cost effective. So in STAMPEDE, we doubled that to 36 months, give or take, but we probably are bolting about 3 years survival on. So you've got 18 months extra buying you an extra several years. So I think it probably will come in under the cost effectiveness radar threshold.
Karim?
Yeah, I guess the analysis will be formally conducted, so we need to wait for that. But I quite agree with Nick. I mean, it's really, of course, balancing the cost with what you're saving on the other hand. Also, at least in Europe, the cost of abiraterone really depends how many patients are receiving it. So it's decreasing if you're using it in more men. So I mean, we need the data, and that's very important. All societies just can't afford all new drugs coming for cancer, so that's really key. But again, given the large efficacy benefit, the good toxicity, and the fact that it's very easy to give this drug, no IV, etc., I think the data will be reassuring.
Excellent. All right, so we have a polling question for the audience. You've heard the synopses of these wonderful presentations and some discussion. So based on the data that we just reviewed, how would you now look to treat a newly diagnosed prostate cancer patient, approximately age 65, with presumed multiple positive bone metastatic lesions and bone scan? He's got evidence of a visceral metastatic disease, perhaps 2 small liver lesions, an ECOG performance status of 0. So your answer options are ADT only, abiraterone acetate and prednisone plus ADT, your choice of ADT, doesn't matter, ADT plus docetaxel, 6 cycles, or ADT plus docetaxel, 6 cycles, plus abiraterone and prednisone. And please assume that whatever country you're working and living in, that there is no regulatory or funding or clinical trial restrictions, that so you have access to all therapies. So while the audience is going through that, Kurt, what are your thoughts regarding the role for some of the other androgen receptor signaling inhibitors out there? Are you aware of any trials or data in this same population that could be compelling or interesting in the near term?
Well, obviously, and we just saw that with the poll, one of the questions popping up now is, should we also combine docetaxel and abiraterone or other androgen-directed compounds? And yes, there is trials underway, like for combining ODM-201 and docetaxel plus ADT versus docetaxel plus ADT and the like. And I think that's going to be the next question, obviously. Is it okay to have a triplet? Or is it okay with the combination of ADT and Abi or docetaxel?
Okay. Fantastic. So now let's go over and have just a quick review of several really provocative abstracts. Karim, please.
Thank you, Neal. So I guess I selected 2 abstracts. One is the Plateau randomized trial that was presented Saturday by Gert et al. And it's really looking at an important question, which is basically in patients who are progressing while on enzalutamide, should we just continue enzalutamide when we're using another drug as a salvage treatment? So this is the design of a trial. Many men were enrolled and screened. So there were men with castration-resistant disease, metastatic castration-resistant disease, who received enzalutamide, and at progression, they were randomized to receive abiraterone plus a placebo or abiraterone plus enzalutamide. So the key question again was, should we continue enzalutamide when it's failing? The primary endpoint was PFS. And there were other secondary endpoints with a key, I guess, secondary endpoint of radiographic progression-free survival. So what the data show is that by the primary endpoint, it's a negative trial. So PFS is pretty much the same, less than 6 months when you're combining Abi and Enza in these men, and 6 months also when you're using abiraterone alone. Now, for the, let's say, key secondary endpoint, there's a strong trend supporting better efficacy for Enza plus Abi, 10 months versus 7 months. And I wonder whether also this is clinically meaningful. Now, if you're looking at the PFS events, it's true that less patients are progressing radiographically when they're receiving the combination, 38% versus 55%, but actually it goes the other way around. When you're coming to clinical progression, which are obviously meaningful, 25% of events in the combo arm versus 18% only in the abiraterone arm. So I'm not sure having an image worsening is really a signal that we should use a combination treatment when the clinical assessment is doing worse. So the conclusion for this presentation is that it's a negative trial. So there's no good reason at the moment, I think, to support combining the two treatments at progression, at least when we're using the sequence of enza first and abiraterone second. And again, regarding the signal in RPFS, I'm not that sure that it's really meaningful, given that the clinical progression went the other way around. I actually prefer having a patient doing well and is imaging worsening if I have to choose. So yes, this is it for this abstract.
Thoughts on the data that from this abstract, Kurt?
Well, we would seldom stick to the sequence ENSA first and ABI then, because what we know from admittedly very small data sets is ABI works not very well following ENSA. So then I'm not sure if that is really relevant for clinical practice, if we should continue giving ENSA in that setting. And as Karim said, it's a negative study. So for me, this is off the table.
Nick, your thoughts?
Yeah, I would agree with that. I mean, we're not allowed in the UK to use, we have to choose one agent or the other. Yeah. Then we have a 3-month window to switch if there are tolerability issues, but after that we can't switch. So this is a non-issue for us, and none of the UK oncologists have felt it necessary to make much of a fuss about this. We don't think the sequence is very good.
There's some interesting things, though, about the theme of is more necessarily better. So here, Enza Abbey, theoretically, maybe it's more powerful. I guess it was trying to show that. But yet, in the Latitude and the Stampede, we combine to get a more powerful response. Different patient populations, different therapeutics, but it's in that concept of not sometimes more is better, sometimes it's not.
Yeah, I think it's in the context of adding things when you're winning versus adding things when you're losing. Yeah. Clearly, the biology is different. Yeah. I think is what you'd conclude, isn't it?
Yeah, absolutely.
So the second abstract I selected is about, again, precision medicine, basically, because this is really something we need more efforts and hopefully more victories about. So we've been trying to identify biomarkers predicting for sensitivity or resistance to Docetaxel for years in France, and this is a report from 2 phase 3 trials that we conducted within the G2X of a French group. And we were looking at various biomarkers that we hypothesized might have a role for prediction with regard to Docetaxel efficacy. So G2X12 is in high-risk localized disease, and we randomized the standard of care of radiation plus ADT plus or minus Docetaxel, and G2X15 is an upfront metastatic phase 3 trial where we were randomizing the role of Docetaxel on top of ADT. So different situations, but basically same questions. Should we use Docetaxel, yes or no? And regardless of the results, we were trying to collect tissue, and we looked at the expression of ERG, PTEN or PTEN loss, Ki67, and NRB. And we were doing that by immunohistochemistry just because at this time we didn't really have a methodology to do much more than that, and we didn't really have access to frozen tissue. So the primary endpoint that we looked at was relapse-free survival or progression-free survival. What we saw regarding ERG is striking. I mean, we know that approximately half of prostate cancer have a TERMS2 ERG aberration. So the TERMS2 gene and the ERG genes are put together, and because of that, this results in increased ERG expression, and ERG is an oncogene. So what we saw was that for patients with a high ERG expression, Docetaxel seems to work. And that was quite clear across trials. For example, when you're looking at time to relapse in GTUC12 relapse-free survival, 80% in men who received Docetaxel, 68% in men who did not. So quite big difference for patients in high-risk localized disease. While for patients with negative ERG expression, there was really no difference. And the same pattern was seen in patients with metastatic disease in GTUC15. For patients with ERG-positive cancers, basically the median relapse-free or progression-free survival was almost double, 19 months versus, let's say, 11. And there was no much improvement in patients with ERG-negative cancers. So perhaps for the first time, and of course we are cautious in that, we still need validation, but perhaps for the first time we have a gene or a protein that might help us for decision making. This is confirmed to try to better select men who are more likely to benefit from Docetaxel. So we're very happy about this data. Of course, we need confirmation to make sure that this is true.
That's excellent. Nick, Kurt, thoughts on this? Getting more precision-based so we really know right therapy, right patient?
I mean, I think, as Karim said earlier on, it's strikingly different between prostate cancer and, say, breast cancer, where the disease has long since been sliced up into different subcategories by biological markers. And it's long overdue, really, that we'd start doing it to prostate cancer, and these data look interesting, for sure.
That's great work. Okay.
Oh, yeah, I can echo this. I mean, that's what we need for the future, to get better differentiation. Now we got many more treatments, and we need to know who is a candidate for this treatment, who is one for the other, and that's a step in the right direction, definitely.
Yeah. Okay, so the two abstracts that I'm discussing, the first one was one presented by Maha Hussein. So this is something we're very interested in because obviously there's an emerging story, as again already mentioned, around patients with certain DNA repair mutations, BRCA2 and so on, being susceptible to treatment with PARP inhibitors. So this is a study that sort of mirrors the TOPARP study which Johan de Bono's group has been doing at the Royal Marsden, which showed that if you had the right mutations, you responded to PARP inhibition. So this is a variant on that, where the group were testing a PARP inhibitor, veliparib plus abiraterone, in a randomized fashion, and then they collected and analyzed the genomic data. So it's a straight randomization, in this case looking at ET status for stratification, and the primary outcome was PSA response rate with a range of secondary outcomes, objective response, progression-free survival, and so on. So on the primary outcome measure for the whole population, essentially this is a negative trial. The PSA response rate is a little bit higher with veliparib, but not statistically significantly so. But the thing that was interesting really relates to the behavior in the different subgroups. So a number of the genes, P10, P53, PI3 kinase, were associated with different PFSs, which is interesting, although oddly it appears not necessarily quite what we expected to see. But also the response rates differed according to whether you had the DNA repair deficiency or not. So basically with the DNA repair deficiency, you saw a much bigger benefit with veliparib, which mirrors the TOPARP study. So, and also various prognostic factors around biological markers. There was some debate as to whether these directions of effects were in the right direction, but I think so the bit that was interesting for me was the association between the DNA repair deficits and the PARP responsiveness going up, which replicated the TOPARP study, and I think that was the thing that was interesting.
Kurt, any thoughts on the use of the trials? There's a lot of them out there now on using PARP inhibitors, and the landmark paper really in New England Journal, Matteo and de Bono's TOPARP study, but now there's just really a plethora of all these trials.
Yeah, I think what Nick mentioned, that's the direction. Probably in the future we're going to test these patients And actually, I do see patients where I discuss this. I mean, PARP inhibitors obviously are not approved for prostate cancer yet, but they are approved for ovarian cancer. And the testing is also approved for ovarian cancer, and that's probably the next step. Interesting thing here was, if I got that correctly, also for even for ABI alone, you saw better results when the patient had this DNA repair deficiency, which is kind of a counterintuitive thing. And so that's something we need to clarify more, I think.
Yeah, I think that the trial was odd in that respect, and
Yes.
the things that we thought should make you do worse appeared to make you do better in the data Maha presented. So, and also the second abstract I'm going to talk about now, it has looked at some genes overlapping and saw the opposite directionality of effect. So clearly there's an issue, I suspect, around validation of assays, how you're doing the tests, what exactly it is you're testing. So this is a sort of variant on one of the papers Karim looked at, which is a crossover trial. So patients were randomized between receiving abiraterone and receiving enzalutamide, and they then crossed over to receive whichever agent they hadn't received, and then you're looking at the time to progression over the whole 2 treatments as the primary endpoint. So is there a better sequence, Abi-Enza or Enza-Abi? And the short answer to that is no. But the thing that is more interesting here was that they collected circulating tumour DNA and looked at the impact. And so there's 2 things that are interesting about this. One is that circulating DNA is a much easier thing to collect than circulating tumour cells. And they were able to show that if you had DNA repair deficits collected from the circulating DNA, you did substantially worse. So the opposite finding to Maha's paper, but I think it's the methodology that's interesting here, because this is a technology that's replicatable. Similarly for P53, AR mutations, RB as well, they were all associated with worse outcomes from circulating tumour DNA, and I think this is coming back to where we started around biomarkers. I think this is a technology that is easier to replicate in the clinic, and I think will find its way into both selection of therapeutics, because you predict the DNA repair ones should be amenable to PARP inhibition. It also raises the possibility you could maybe use it for monitoring. Does the circulating marker disappear if you give a PARP inhibitor, for example? That wasn't obviously addressed in this study, but it's a very obvious extension from it, I think. Okay, so as I said, in terms of the Abi-Enza, Enza-Abi, there's no difference. It doesn't matter which way around you do it, and I would argue just do one. But it was the circulating tumour DNA outcomes which were interesting, because they both appear to have prognostic significance, but potentially predictive significance in relation to therapeutics that are now in clinical trials.
Okay, so just closing in on time. So we have the audience poll response. So, and here we have based on our polling question, here is our polling question, and here is the response to by percentages.
Drum roll.
So yes, a drum roll, please. So how would you now look to diagnose this patient who has high-risk androgen-sensitive metastatic disease with a good performance status? ADT only, 3%. Okay. ADT plus abiraterone acetate and prednisone, 79%. ADT and docetaxel, 3%. ADT, docetaxel, abiraterone, and prednisone, 14%. Are those results surprising to you, or is it...
That's what you would expect. I mean, we just presented very convincing data, so, that's how the mind works. What you heard last, that gets stick in your brain.
But didn't you say in your session you thought it was still did the audience get polled and there was about almost an even split still, or?
Well, the question was more, would you use just one treatment or would you combine? Okay, so more, I guess more people were keen to combine already, while probably the other half, or maybe 2/3, I can't remember, were more keen to wait for data before combining. Now, I'm not that surprised neither. Again, and remember when you asked the question, you told people, this is assuming the drugs are available in your country, there's no restriction. So basically, if you try to compare the various trials, the feeling is that Docetaxel and abiraterone have, let's say, quite similar efficacy, overall survival benefit, even if it's not that easy to compare. And people will obviously choose the less toxic compound. My answer would have been randomize C and D, and this is actually what we're doing, because at the end of the day, we really want to know whether 3 drugs is really better. And hopefully we'll have the answer in a couple of years from now.
Okay, that's very well said. So I would like to give the panel an opportunity to just have some concluding statements, your thoughts on what we've discussed today, ASCO, the groundbreaking trials that you've both been championing. So let's start with you, Karim.
Well, I think maybe I will come back to what Eric Small said during his discussion of my paper, which was at the end of his talk, he reminded people that basically we've been using castration alone for 70 years for these men with de novo metastatic prostate cancer, with a long series of negative phase 3 trials. And this changed back in 2015, so just 2 years ago, with a demonstration that Docetaxel should be used at least in fit patients, with a debate about how many metastases, all these things. But clearly, practice changed 2 years ago. And now, 2017, we're changing again the field and the standard of care with abiraterone. So we've just continued changing the field like that and accelerating research. That's going to be fantastic for the patients.
Great, thanks.
Yeah, absolutely. I mean, I can only agree with that. I think as always, when you make an advance, you create new questions and new problems. And I think how we manage, I think practice will change. I think clinicians and patients are mostly going to prefer abiraterone over docetaxel. I think there may well turn out to be a role for docetaxel and abiraterone, and Karim's Piece 1 study is going to be extremely important in answering that question. I think we will then be faced with quite difficult problems as to what you do. If you've had docetaxel, abiraterone, and then you're castrate refractory, you're kind of running out of options. So I think we will have a whole raft of new problems to deal with. As always, you answer one question, you create another one.
Yeah, well said. We're just trying to keep these folks, if not cured, alive as long as possible, out of the emergency departments, out of the hospital, quality of life.
Well, you see, if you did indeed prolong survival by 25% by bolting docetaxel on top of abiraterone, you're already at 7 years or so for median survival of metastatic. Another 25%, you're out at 10. Yep. So, that's starting to look pretty good.
Yep.
Yeah.
Thank you. Kurt?
Yeah, it's kind of disruptive innovation, I would say. Yeah, come on, it's like the iPhone, but it's a little bit easier to use. So I think, it's the good thing is really, it took some time until the docetaxel thing was adopted, also for the urologic community. This is much easier. So it's a low threshold thing to get this in your daily practice, and I think that's what's going to happen. And it's, as Karim said, it's good for all patients.
Yeah. Well, great final comments. I don't have anything to add other than to say thank you so much for your presentations, your participation, the leadership you've shown. These are not easy things to accomplish, these large trials, and getting the patients in. You had huge numbers of collaborators that I know you're both incredibly grateful for, and all the patients and the families, and we're doing so much better in prostate cancer. It's really remarkable. And you said earlier, Nick, what's happened in the median overall survivals have changed significantly in the last few years, thanks to all of this research. I want to thank the folks from eCancer. If you want to watch the program again, you can go to ecancer.org. If you've got other colleagues who want to see this, that you can get to that as well. It'll be on and archived for some time to come. So again, gentlemen, thank you so much. It's been great to share this time with you at ASCO, and thank the audience for listening.